All right, guys. Why don't we go ahead and get started? It is good to see you all again. I've actually never lectured in this room before. It's a little bit disorienting, but it's good to see you guys. Congratulations on making it to the end of med school. For those of you guys who are in early match programs, congratulations on matching. And for the rest of you guys, I'm sure you're anxiously awaiting match day. There is poll everywhere in this presentation, so go ahead and try to log on to that. You guys remember Allison Zazulia, Neuro? So Allison's a good friend of mine. She had challenged me to put in a fun, non-work-related slide in the beginning of each talk. She thinks it helps promote wellness. So I hope this makes you guys feel well. And also apparently helps to make your speaker more than a talking head and humanizes me or something like that. So anyways, in honor of Allison, here's my non-work-related slide. This is my son, Isaac, who's 2. Doing what many of you probably wanted to do to me after the renal exam, which is kick me in the face. He's adorable. He is having twin sisters joining him in less than a month, which is why I have my bag with me in case something happens and I have to run, which is a terrifying thought. So I was given this objective to talk about everything you need to know with potassium, magnesium, calcium. Originally, sodium was in there also, and I told them that's sort of an impossible task. So we shifted the sodium content to Dr. Goldberg. I'm going to talk mainly about potassium, because of all these electrolyte disorders, potassium is really the only one that's going to kill a patient pretty quickly. The others can do bad things, but they usually take a while to get there. So specifically, what I want you guys to be able to do is make a differential for each of these electrolyte disorders, interpret labs, interpret EKG findings, be able to make a basic recommendation of what to do. So if you're on night float, or if you're covering a bunch of patients overnight and you get a hyperkalemic case, I want you guys to at least feel like you have a starting point, like you know what to say when you get off the phone with the nurses, and then identify common pitfalls when you're trying to correct problems. I totally know that you guys have 3 hours of renal to start off this day, which can be really tiring and really difficult. So I'll try to make this all case-based as much as possible. And I am pretty sure even though we're starting late, we're going to end ahead of time, so you'll have a little bit of a break. Hello. Okay, case 1. You'll notice that most of these cases are not black and white content. It's not like, what is the side effect of hyperkalemia? They're a little bit more judgment-y, because I think one of the hardest things that you'll deal with as interns is making those judgments. When do I worry? When do I not? When do I intervene? Which choice do I make? So here's the case. You've had a long afternoon clinic. You go home, you lay on your couch, you watch C-SPAN. I don't know who in the world actually watches C-SPAN, but for this case, let's say you're watching C-SPAN. You get interrupted by Trixie, who works in the lab, and she's calling to tell you about alert values for one of your clinic patients. All right, this is a diabetic patient. He's got a potassium of 5.5. This is very frequently, you'll get called on panic labs or abnormal labs all the time. The rest of his BMP, sodium's 138, chloride's 106, bicarb 24, BUN 12, creatinine 1.8. That's not really new. This patient's baseline creatinine is between 1.6 and 1.9. And our warm-up question, just kind of get the juices flowing, is to think, do you worry about that or not? Or what's the extent of worry? Do you need to call this patient back and say, hey, you need to go to the emergency room, get your potassium rechecked, or is this something that can wait? All right, let's see what most of you are thinking. So a small amount of you guys think that it is important to call the ED, get this patient seen, evaluate what that potassium is. The majority of you guys think, no, it's really not an emergency. They don't need to go to the ED for this. My personal response would be, nope, it's not an emergency. But let's talk through why that's the case. So when do you really worry about hyperkalemia? The normal range, depending on what lab you will be using, upper limit of normal is usually 5. Some labs go up to 5.3. So most of the potassiums that fall under that, nothing you need to worry about. When do we get to the I need to do something right away level of hyperkalemia? There are 3 things that will help you determine when you really need to worry. One is whether the patient has symptoms. The second is the actual serum potassium level. And the third is their risk factors. These are three things that you should be thinking about to determine whether or not you really need to worry. So starting with symptoms, fatigue, weakness, palpitations, paralysis usually only occurs when potassium levels are extremely high. But those are fairly nonspecific, right? You could have a flu and have fatigue and weakness. You could have a renal exam and feel fatigue and weakness. When the patient comes in and they roll in with paralysis, honestly, hyperkalemia should not be the first thing you think about, right? Nor should it be with palpitations. So this is why a lot of times physicians will jump to EKG changes. Just as a reminder, EKG changes, imagine that you're standing at the end of that T wave. You've got your fishing hook around the T wave. As you pull that up, the T wave is going to get pulled up. And then you're going to spread out your QRS. That's going to widen. And then your P wave is going to flatten. All right? Easy things to remember. How tall does that T wave need to be for you to worry about it? There's no consensus criteria. Some people will say 5 millimeters in a limb lead, 10 in a chest lead. But that's sort of hand waving. There's no study that's looked at what exactly constitutes a peak T wave. Informally, if you ask most of the medicine attendings, we will tell you that if it looks peaked enough that it would hurt to sit on, that is a peak T wave. All right, again, not really specific, but the criteria just aren't there for it. How good are EKG changes for hyperkalemia? And it turns out that they're not great. They're not very sensitive at all. This was a study of 90 patients in Connecticut. And you can see, yeah, there is some correlation that as potassium levels get higher, your likelihood of finding EKG changes goes up. But notice it's not a sensitive test at all. There are plenty of patients who are sitting around with Ks in the 9s who have no EKG changes at all. There was another study that was done that looked at about 200 patients and actually suggested there wasn't even correlation between severity of the hyperkalemia and EKG changes. So it gets looked at all the time. The data is not there to support this as a great measurement of severity. Yeah?
Is this thought to reflect that these patients actually weren't experiencing any sort of conduction changes, or is it just that EKG is not particularly sensitive to minor disturbances?
I think the thought is that the EKG is just not sensitive to these particular kind of changes. Maybe if we had better criteria, maybe if it was outlined a little bit better, we could pick up more subtle changes, but right now that's it. So the next thing we'll look at is the serum potassium level. So even though on medicine you probably have gotten worried or your team has told you to worry about potassiums that are higher than 5.5, severe hyperkalemia is actually 6.5 or higher. All right, that gives you a lot of leeway before you really need to worry. 6.5 is sort of the range where you worry about imminent complications, right? Tachyarrhythmias, things like that. Mild is less than 5.5, moderate is between 5.5 and 6.5. Now, 6.5 or higher is severe. You probably don't want your patients to get to that point. So personally, I usually worry when potassiums are greater than 6. All right, it's not in that severe category, but I want to just make sure my patients don't get to that range. A little bit different for me because I mainly see patients with kidney disease, and so they don't get rid of potassium efficiently, so they will always be at risk for chronically retaining potassium and having that potassium get higher. But I think that's a pretty good threshold. Potassium's greater than 6, worry a little bit, make sure it's not getting higher, have a plan for how you're going to correct that. Here's a study that was done that actually used that cutoff of 6, and you can see in patients who had the dark bars, that's potassiums of 6 or greater, your odds of having some awful outcome are increased. Notice also that as you have worsening CKD, those odds of death or complications are actually a little bit less. That's because patients who have chronic kidney disease, their bodies, they never get rid of all their potassium, right, because they've got chronic kidney disease. Their bodies start to get a little bit used to having higher potassium levels, and they upregulate other things to deal with that, including stool. They increase their stool excretion of potassium. So that's probably why when you look at a graph like this, patients with stage 5 CKD don't have as high of odds of developing complications with the high potassiums. All right, and the last thing you look at is risk factors, especially people who are at risk for further generation of potassium. So crush injury patients, right? They're in rhabdo. They're going to have ongoing release of potassium from intracellular stores. You worry about those people. People who have tissue ischemia, you worry about those individuals because they're going to have continued poor perfusion to tissue, tissue's going to die, release potassium. I don't have it on here, but patients with chronic kidney disease, patients with acute kidney injury who maybe aren't making a lot of urine, you worry about those patients because they're not going to get rid of that potassium load. So then you think about, how do I treat hyperkalemia? And unfortunately, we do have to take a little detour to pathophys, just because how you treat the patient depends on how they got hyperkalemia. Any electrolyte problem, the differential, your approach to the differential is always the same. Think of input, think of output, think of transcellular shifting. In hyperkalemia, that input contribution would be from a dietary load of potassium that's greater than what you can pee out. The excretion part, the output, is from inability to urinate, right? Because remember, about 95% of your potassium load is gotten out of your body through the urine route, not through stool. That's why constipation is not a risk factor for this. And then shifting, you think of things that are causing potassium to leak out from intracellular to extracellular. Remember, most potassium is in the intracellular stores. It also turns out that intake is fairly rare as a cause of hyperkalemia because we have so much of an ability to dump out potassium. So it only really occurs if it's coupled with some kind of kidney problem, either a decreased GFR from volume contraction, CKD, acute injury, a decrease in aldosterone. Remember, aldosterone is like that pump that tells your body to dump out potassium. So ACE inhibitor, ARB, aldosterone antagonist, NSAIDs, anything that's going to decrease your aldo levels are going to put you at risk for high potassium. What can cause shifting? Conveniently, it works out to like an ABCD kind of mnemonic. A for acidemia, non-organic acidemia, so things like RTAs, things like acidemia from diarrhea. That acid is going to shift into cells. Potassium is going to shift out. Beta blockers cause this cellular lysis. Again, you're ripping open cells. That potassium content is going to be released. And then two ways diabetes can do this. One from insulin deficiency, and then the second is from hyperglycemia itself. High blood sugars are going to draw water out from the cell into the blood, and as that water moves out, it's going to carry potassium with it. So in our patients, diabetic, potassium 5.5, I'm going to tell them they don't need to go to the emergency room, but I'm going to review their diet. What are they eating? Are they eating foods like bananas, tomatoes, potatoes, avocados, orange juice, things that are high in potassium? Maybe they can cut that down. Are they taking things like ibuprofen, things that might be blunting their aldosterone response? And if so, stop taking that. Do they need a diuretic, right? Do they have a little bit of edema and they could benefit from a diuretic that'll help them pee out more potassium? Or are they acidemic, and you can give them some bicarb to neutralize that and correct the acidemia that way. Okay, that's easy. Moving on to something a little bit more nuanced. We have a 68-year-old in the hospital, just had a BKA, for those who are in surgery. They've got osteomyelitis, they've got vascular disease. That's why they had, say, a non-healing wound. They got their leg cut off. Overnight on surgery, you get a call, and the BMP shows a sodium 135, K is 7.6. Chloride's 100, bicarb 21, BUN 46, creatinine 2.1, glucose 98. For the sake of this exercise, let's say the patient's got chronic kidney disease. All right, so that 2.1 is not too far off from baseline. Here's an EKG. Does that T wave look like it would hurt to sit on it? Maybe, right? That looks like it might hurt. So you're on nights, you turn off C-SPAN, you get your calcium gluconate ordered, you get some insulin and glucose ordered, you repeat potassium about an hour later and it's down to 5.0. What do you call your current situation? You had a K of 7.6, it's down to 5 now. A decisive victory, like your night float and you owned it and you did great. Sort of a temporary thing, you've got a little bit of a respite. Or Ragnarok, which is arguably the best Marvel film, maybe the last Avengers movie, but debatable. All right, let's see how you guys did. So most of you guys think of this as a temporary ceasefire, and that is the correct answer. Of note, this was an actual case. This was an M&M from several years ago. On surgery, the patient got all of the temporizing measures. Potassium came down to 5. They went back to sleep, didn't do anything else. The next morning, the patient coded and died. And at the time of the code, the K was back up to 7. So important things to remember. Temporizing measures are exactly that. They have an immediate effect. within an hour or so, you're going to get those potassium levels down, but they're only temporary. So what are the things that we usually use for that? Calcium gluconate, insulin, albuterol. Why do they work? Just a reminder, calcium gluconate does nothing to lower potassium. It just stabilizes membranes, right? So when you're hyperkalemic, you get a little bit closer to that threshold for membrane excitability. When you give them calcium gluconate, that threshold goes up. When you give people insulin, you are stimulating the sodium-potassium ATPase. What is the point of that? It's going to take potassium that's in your blood, and it's going to shift it into your cells. And the same thing with beta agonists, like albuterol. It's going to stimulate sodium-potassium ATPase, move that potassium into cells. This is like putting a temporary spare tire wheel onto your car after you've popped a tire, right? It's only intended to be a temporary fix, unless the only reason the potassium is high is because of a shift. So glucose went up to 500, potassium went up to 6. You give them insulin, glucose comes down, potassium's going to come down. So when we think about our algorithm, right, on this end we have, yes, we're worrying about the potassium. You're going to temporize them. Your next question is that just a transient thing because of shift, which is mainly from hyperglycemia or metabolic acidosis? If that's the case, just treating that underlying problem is all you need to do. Give them insulin or give them bicarbonate. And if the answer is no, you need to still get rid of that extra potassium load. How do you do that? Remember, 90 to 95% of your potassium load is dumped out of your body through the kidneys, right? So your main thing you're going to do is to get them to pee. Do you use fluids? Do you give them a diuretic? Do you do both? It depends on your exam of the patient, right? If they look a little bit dry, if they've been MPO for a couple days for their procedure and they look a little bit dry, if they're orthostatic, if their blood pressure is low, give them a little bit of fluid. Prompt that urine output, and you will dump potassium after that. If they're a heart failure patient, a CKD patient, they've got a little bit of pulmonary edema, go the other route and give them a little bit of Lasix. Anything you do to prompt urine output will make them pee out more potassium. Option 2, which really should come second to making patients pee, is to make them poop it out. And again, remember, for the most part, pooping only accounts for about 5, maybe 5 to 10% of potassium excretion, so not the most efficient agents. All of our potassium agents are exchange resins. This is important. That means that when this thing passes through your gut, it's going to take potassium in, but it's going to exchange it with something, and you need to know what it's going to exchange potassium with. So what used to be the most common exchanger was Kayexalate. Kayexalate's now associated with bowel necrosis. People actually think it maybe doesn't even work. Now not used as often at all, right? The next one that became approved was something called Patirimer or Valtessa. This is not approved at Barnes, so you guys probably have little to no experience using it, but I will tell you about it because the programs that you go to might have this agent approved for it. Patirimer is dosed at 8.4 grams once a day. It's usually dosed every day. You get an initial effect, maybe 4 to 8 hours, but peak effect in lowering potassium actually does not happen on the order of weeks. All right, so it's meant to be a chronic medication, not an acute lowering agent. The exchange resin in Patirimer is calcium. It binds up potassium, it releases calcium. If you have a patient that's hypercalcemic, they should not be getting this. You're only going to increase their calcium load. If you have a patient with really bad vascular calcification, maybe you need to think twice about whether or not you should be giving patients Patirimer because you're going to be giving them more calcium. It does work. Like I said, it'll bring potassium levels down by around 1 milliequivalent per liter. It'll have its initial onset 4 to 8 hours, and then it really takes weeks to have its full maximal effect. At Barnes, you may be familiar with an agent called Lokelma. Lokelma is what they use on the Barnes formulary. Some of you will be using that as an outpatient. Lokelma is kind of weird. Unlike other GI binding agents, it actually has an effect within an hour. All right, so within the first 2 hours, you can get potassium down by about 0.3 or 0.4. And then its usual full effect happens at about 24 hours. Dosing of it is 10 grams. You can give it up to 3 times a day. So it's weird in that it actually can work more acutely than any of the other stool binding agents, and it's pretty effective.
Actually,
Yeah?
the other ones that you were showing that took a couple weeks, is that with
So that's from daily dosing. Patiromer and Kayexlate were intended to be chronic medications for patients who have like ESRD but not a dialysis candidate, so you're just trying to keep them alive and keep their potassiums low. So those are patients who have been on that for patiromer, 10 grams every day, not just to load in the hospital. One of the problems with agents like patiromer is, not surprisingly, once you stop it, unless your dietary input changes, your potassium just spikes back up again. For those of you who are doing general internal medicine or family kind of medicine, a lot of times you will use patiromer or Lokelma to help patients tolerate an ACE inhibitor. If you start them on an ACE and they get hyperkalemic, but you really want to keep them on it, you'll put them on patiromer and just keep them on it forever. Before I forget, Lokelma, the exchange resin is sodium. I cannot tell you how many times people have come into Barnes, got put on Lokelma without a great reason, and then come back to the hospital with volume overload. If they have heart failure, if they're at all at risk for developing bad edema, pulmonary congestion, you do not want to put these patients on Lokelma. Last resort is, not surprisingly, dialysis. Dialysis is, of course, really effective at lowering potassium. You're taking all their blood and running it through a machine. Why is it considered last line? Well, you've got to jam an access into a patient, right? So you're putting a huge ass catheter into their neck or into their groin, which is a portal for infection. And then treatment issues include hemodynamic stability. When you run blood through a machine like that, you can drop blood pressures. And then sort of emerging data is potassium flux actually puts patient at risk. So obviously a potassium of 9 is dangerous to a patient, but if you drop them from 9 to 5 in an hour or two, like we used to on dialysis, you actually increase their risk for arrhythmia. Another way to think about this, ESRD patients, if they're Monday, Wednesday, Friday, they are most likely to die on Monday morning Monday, like at their dialysis treatment. If they're Tuesday, Thursday, Saturday, they are most likely to have increased mortality on Tuesday at their dialysis treatment because their potassiums during that time are going to go from whatever accumulated over the weekend down to something really low. So there's something about that flux in potassium that actually puts patients at increased risk. That's why dialysis is the last line. So here's our algorithm. If we need to get rid of potassium, question 1, can you make the patient pee? If the answer is no, like they're ESRD, you call renal because inevitably we'll have to dialyze them. If the answer is, yeah, I can make the patient pee, then do whatever it takes to try to make the patient pee. Recheck potassium. If it's better, celebrate. That's your victory. If not, you can try a stool binder. And if that doesn't work, then you go back to calling renal. All right? This algorithm is in the handout for this session, which I think is a really handy-dandy thing. Just print it out, keep it in your white coat pocket. I think it'll save you some trouble when you're an intern. Okay, there's a patient in the emergency room for altered mental status. Potassium is 8.7, bicarb 12, BUN 185, creatinine 29. What do you want to do next? Lokelma, Lasix fluids, or put the dialysis catheter in? Okay, most of you said put the dialysis catheter in. This was an actual patient. My fellow called me in the middle of the night and said, here's the situation, patient's in the ED. Should I go ahead and put a dialysis catheter? And my answer was yes, but. So then the question is, what was that but about, right? So most patients like this, it seems like a no-brainer. Yeah, they're going to need dialysis. Their BUN is 180, 190. Their creatinine is 29. But what if there's a very reversible cause of this kidney injury, right? So this particular patient came in, had mental status changes. In the ED, it was noted that he smelled like urine. He had likely been incontinent. So I said, go ahead and get the kit, get the ultrasound, get ready to put a dialysis catheter. But just while you're getting everything together, tell the ED to put a Foley in and see what happens. So Foley went in, 3 liters of urine came out, and I told the fellow, wait, just hold on just a second, right? They rechecked it almost immediately, which was 2 hours from the initial labs. Potassium came down to 7.2. Creatinine came down to 22. I said, give the patient fluids. Make sure you can continue to have a good urine output. and within 8 hours, K was down to 5.5. So the lesson here is, yeah, immediately you would think this patient needs to be on dialysis. Nobody in the world would fault you for saying this patient, you need to at least make plans to get the patient started on dialysis. But it sort of emphasizes if patients can make urine, if they have a reversible cause of kidney injury and you can reverse that quickly, they will get rid of that potassium faster than Lokelma can. Right? You'll notice this 2-hour point, this came down from 8.7 to 7.2. That's a lot faster than the 0.5 than Lokelma could have done it. Dialysis itself, if we put a catheter in, you're getting a machine, you're priming it, you're putting the line in, you're getting an x-ray, you're waiting for placement. That's about 2 hours. Maybe we could have corrected it quicker with dialysis, but then we would have increased that potassium flux. Right? So again, no one's going to blame you if you think the right answer to this is put the dialysis catheter in. I thought that was what's going to happen. The fellow did also, but this just emphasizes if there's potential for reversibility, the kidney will correct hyperkalemia faster than anything you can do will. I have 2 of these slides in, which are completely not related to anything, but just sort of fun as you guys think about starting internship soon. So during internship, there were moments where I felt completely overwhelmed. Which of the following did I do during an in-house call? Did I throw my pager into Lake Michigan? So I was at Northwestern, I was in Chicago. Did I storm out of the hospital saying I quit? Did I hide under a desk? Or did I vomit on a patient? The funny thing is, the last question on the response, like we waited a minute and there were like 18 responses. This one we get 36 in like 10 seconds, which is great. Most of you thought I vomited on a patient. I'm actually not a vomiter. I haven't vomited in actually like decades now. It's been a long time. I've totally just jinxed myself. I actually hid under a desk. There was like a little room that the physician stayed in. The nurses kept bothering me. I just hid under the desk, pretended I wasn't there, and it was really embarrassing, but that's what I did. You'll have times like that too, where you just want to hide and disappear for a while. Okay, real quick, hypokalemia. The differential is the same, intake, shifting, output. Intake, you're not thinking of too much potassium, you're thinking of too little, so people who are really malnourished. Shifting, you're thinking of things that will shift potassium more into the cells. And output can be either from urine output, started a patient on a diuretic, for example, and they peed out a bunch of potassium. You can have massive diarrhea, which can cause hypokalemia also. So Bob is on a cruise. Nowadays, you worry more about coronavirus, but for him, he got a GI virus. He's got massive diarrhea. His K is down to 2.8, bicarb 17, creatinine is 1.4. How much K do you want to give him? Most of you went for 40 milliequivalents. So this is one of these judgment kind of things where there's no right answer, but I'm going to tell you what a good starting point is going to be. My answer would have been 80 milliequivalents. So the only real firm answer is that once potassium levels are under 3, you've got to give them a whole lot of potassium back. Once potassium levels are under 3, the potassium deficit is gargantuan. What I would generally recommend, and again, this is in your handout thing, is if potassiums are less than 3, you are looking to give them at least 80 to 160 milliequivalents in the next 24-hour period. Okay, if it's above 3, you can be a little bit more modest with that, give them a total of between 40 and 80. But I would just make sure that you're going to replace enough potassium in these patients. Why that much? Think about it. Most of your potassium lives inside cells, right? So as you decrease your serum potassium, you're going to have some buffering. You're going to release some potassium from your cells into your plasma space to try to attenuate that. By the time you get down under 3, you have total body depleted a ton of both extracellular and intracellular potassium. So you need a large amount to get that back. As I said, there's no absolute rule. These are beginning guidelines. What I would recommend is you start with this, and then you recheck labs and just see how am I doing with correcting potassium. So again, nothing replaces careful monitoring. This applies to hyponatremia also with Dr. Goldberg's lectures, right? Because humans aren't black boxes. You could supplement potassium, but we are still peeing, we are still pooping, we are still losing water or losing potassium. So in this case, Bob gets 80 milliequivalents, and you repeat labs, and his K is now down to 2.7. So again, this doesn't happen infrequently. You think you're doing the right thing, you're giving a lot of potassium, and the potassium doesn't respond or it stays low. How do you troubleshoot that? One, think about ongoing losses. Is the patient still having diarrhea? Because if they are, you've got to take in that account for how much potassium they're losing through their gut. Do they have NG suction where they're losing stuff? Or are they on a diuretic? Or are they hypomagnesiemic? And you have to keep up with those causes of ongoing hypokalemia. Very often what happens is that you've just underestimated the deficit, either because the potassium deficit is huge, or because there's something that's masking how severe that deficit is. So, talking about that, in this case, here's our patient. Potassium was 2.8. Notice also all right, so potassium's 2.8. We've made a bunch of potassium disappear from the blood space. Notice his bicarb is 17. His anion gap is 11. He has a non-anion gap metabolic acidosis from his diarrhea. What happens with metabolic acidosis? You've got these protons that are in the blood giving you the acidemia, and your cells are going to buffer that, right? Protons are going to move into the cells in exchange for potassium. So you put out a bunch of potassium into the blood space, and it suddenly makes that potassium not look so bad. So that 2.7 or 2.8 potassium that the patient had is actually a little bit falsely elevated because of the metabolic acidosis. So that 2.8, falsely elevated from that low bicarb, you're going to replace his bicarb deficit, improve his volume status by giving him some LR, and now his bicarb is better. It's going to unmask the severity of that hypokalemia, and that's why his potassium dropped. All right, so a lot of times this will happen, and I just don't want you guys to be discouraged, or I don't want you to think, oh, I'm totally on the wrong track. It's just that you've unmasked the thing that's propping up the serum potassium levels. In a case like this where the patient has diarrhea, it's also important to make sure the patient doesn't have hypomagnesemia. Right? Magnesium is important in potassium conservation. You can lose it through your kidneys, mainly through diuretics. Alcoholics, for some reason, also have an increase of magnesium wasting in their urine. Diarrhea, pancreatitis, very common causes of GI loss. For those of you who are doing medicine, very common medicine board question, proton pump inhibitors also increase GI loss of magnesium. You can almost always identify the source based on HPI. Did you start a diuretic recently? Are you having massive diarrhea? Right? If you wanted to get real fancy, you could calculate a Phe magnesium, which is just like a FeNA, except you use magnesium instead, and you multiply it by 0.7. That just reflects the distribution of magnesium, which is predominantly intracellular or in bone spaces. And your cutoff, instead of a FeNA of 1, a Phe mag of greater than 2 suggests magnesium wasting. This is on MedCalc. You don't have to memorize it. It's just a handy tool that you can use. Honestly, your HPI gives you the answer before you need to use this almost all of the time. Treating hypomag. You can give them oral magnesium. Oral magnesium needs to be given regularly. You can't just give one dose and expect it to get better. So usually it's 400 to 1,600 milligrams per day of magnesium oxide, and you'll usually need to supplement them for weeks to months. How many of you guys have had that experience in the hospital? A magnesium was less than 2, and your resident said, give them a 2-gram rider of IV Mag. Does that happen to you guys? Lots of you guys have had that happen. A great way to make that magnesium look better instantaneously, but IV Mag is incredibly inefficient. So what happens is you put an IV in a patient, you give them magnesium, immediately their serum magnesium levels go up because magnesium takes a long time to redistribute into cells and into bone. And your kidney senses this, and you actually increase renal excretion of magnesium. So if you really have a patient who's hypomagnesiemic, yeah, you can give them an IV Mag rider. 2 grams is a great place to start. That will bump up your labs so that by the time you're attending rounds, the magnesium will look nice and shiny and perfect. But if they really have a deficit, after you give them the IV Mag, you should put them on oral Mag to make sure that you're actually slowly replacing it, because the body will pee out a lot of that IV magnesium content. Okay, 64-year-old dialysis patient comes in for blah, blah, blah. Does it really matter? They came in for something. After dialysis, labs are checked. Sodium's 130, potassium's 2.6, BUN 30, creatinine 3.2. What do you do next? Okay. So, most of you went with recheck labs in 2 hours. A couple of you thought, well, he just told me a low K means there's a huge deficit and we should give 80 milliequivalents of potassium. So that's what I'm going to do. This is the only example of a time where there's a caveat to that rule, okay? And that's with dialysis patients. After dialysis, labs are completely crazy. For the 2 hours afterwards, the plasma space and the intracellular space have not re-equilibrated, so you should never check labs during that period. In this case, the residents did exactly what you did, which in any other scenario would be the right thing to do. They gave potassium. The next morning, the K was 5.9, and we had to dialyze the patient again. So really, the take-home message from this case is just when you are an intern, when you have patients who are on dialysis, don't check any BMP within 2 hours of their dialysis treatment, because something will show up on those labs that will make you panic, and then you'll try to supplement something, and you'll end up doing more damage. So just wait 2 hours, and then recheck the labs. Okay, very quickly, we're going to do the calcium disorders, and then we'll be done. 57-year-old man comes in. He's got chronic back pain. Primary care doc noticed his hemoglobin was down to 5.5 and got him admitted to the hospital. On admit, he gets a BMP that shows his calcium is 11.2. What's the first thing you usually think about with hypercalcemia? It's usually volume, right? Volume contraction causes elevation in calcium. So first thing you think of is patient volume contracted? If the answer is yes, you volume resuscitate them and recheck. But in this case, you give the patient volume back. They're feeling a little bit better. You give him some blood also to get his blood counts up. But his calcium remains elevated. What's the most important lab to check next? So calcium 11.2, you volume resuscitated, still high. What do you check? Most of you went with PTH. PTH is the correct answer. What you do next for hypercalcemia, a lot like hyperkalemia, is going to depend on what the underlying problem is. So when you check a PTH, you're going to figure out, is this primary hyperparathyroidism, or is this from something non-PTH related? Right? If the PTH is appropriately suppressed, then you start thinking about things like malignancy-related or granulomatous diseases or myeloma, and then the workup is a little bit different and the treatment is a little bit different. But overnight, when you get called on things like this, step number 1, volume resuscitate. Step number 2, send off an intact PTH. That result usually doesn't take that long to come back, so you can at least get an idea of what's going on with your patient. What are the agents that can be used? By the time it gets to this stage, usually a senior resident or an onc fellow will be involved. So really, you shouldn't have to worry so much about bisphosphonates, usually used in the setting of malignancies. Steroids you're usually going to be using when you're suspicious of a granulomatous disease, fungal diseases, TB, sarcoid. Denosumab, dialysis, definitely not things that you should prescribe as an intern. Denosumab because it costs so much. Dialysis because that ends up being the renal fellow's call. Calcitonin. Calcitonin is benign. It doesn't hurt the patient. It will get a calcium down. It doesn't last for long, but it will buy you time to be safe throughout the evening. I would tell you, if you get stuck in the middle of the night, you're waiting for an intact PTH, and for some reason you feel pressure like you've got to do something, you can give the patient calcitonin. There's very little long-term consequence of that. Right? This is sort of like I'm going to use this to buy time. This is just like when you're an intern, you should always have a line ready when you get pimped just to say something, which for me used to be like, that's a really good question. Let me go back and think about the pathophysiology. And as I said that, I would kind of think about what I was going to say next. You should always just have like something ready to say to buy you time. In hypercalcemia, that thing is calcitonin. It just buys you time. How about hypocalcemia? We've got a 63-year-old guy, ESRD, comes into the hospital for bright red blood per rectum. His hemoglobin is 4. His calcium is 9.1 initially. He gets 42 units of blood, real patient from last month. Calcium drifts down, it's now 6.1. Why did this patient get hypocalcemic? Calcium is now 6.1, albumin is 3.4. Is it titration from calcium, low vitamin D, high phos levels, or is the calcium actually normal when you correct it for the albumin? In the interest of time, I'm going to zoom on through. Most of you guys saw the 42 units of blood, figured there's a lot of citrate in blood. It's going to chelate the calcium and cause hypocalcemia, and that is correct. For those of you who are wondering, oh man, what was that correction thing for albumin? So normal albumin is 4 minus albumin times 0.8. That's your correction factor. You add that onto the serum calcium, and that gives you what the corrected calcium should be. You can also check an ionized calcium, which is very helpful. I'm not going to ask you guys to memorize this, but again, it's on your resources. Keep it in your pocket. When you're stuck in the middle of the night, you can always give a patient an amp or 2 of calcium gluconate. If you, are any of you guys going into ENT people? If you take a parathyroid gland out and the patient gets hungry bone syndrome after that, they have persistent hypocalcemia, you need to run a drip afterwards. And again, in your handout, I have exactly how to do that drip. You usually start a calcium gluconate drip at 50 cc's an hour. And in case you go to an institution where the pharmacy doesn't know what you mean by calcium gluconate drip and they want you to say exactly what that is, the little ingredient formula is down here for you guys, okay? It's basically a liter spiked with 100 cc's of 10% calcium gluconate. Okay, as my time is rapidly elapsing, 5 quick things for you to think about when you start internship. Number 5, you should all consider renal. Even if you're not doing medicine, it's not too late to quit and go into medicine and do renal afterwards. Number 4, don't sacrifice your humanity for your training program. Years ago, the CTICU program had a fellow who asked for some time off to get married. The program director told him, you can get married any number of times. You can only do this fellowship once. Don't buy into that kind of thing. You have a life. It's important to defend your humanity. Number 3, don't be afraid to ask for help. It's a lot better for your patients if you ask for help and do the right thing than if you kind of flail around and maybe do the wrong thing. Number 2, you guys are from WashU. You, without a doubt, are going to be some of the smartest people in the room when you do residency. But don't assume that you are the smartest person in the room. There are times that you're going to see something a consultant recommends, and you're going to think, that makes no sense at all. I know better than them. I'm going to do this other thing. You guys are going to go to programs that are very prestigious, right? It's important when you have a conflict like that, talk to the consulting attending. It might just be that they are so brilliant that they had an idea that you hadn't thought of. So just be careful. Before you criticize other people, just make sure you know what you're talking about. And number 1, you will make mistakes. This is part of training. Don't be afraid of that. You have people supervising you. Don't beat yourself up. This is just part of the natural part of growing as a physician. And my last poll everywhere. Like many nephrologists, I look a little younger than I actually am. Think about this. Will Ross, Tim Yao, like we all look a little bit younger than we actually are. This can be a disadvantage. So which of the following, and that's illustrated by which of the following that actually happened to me? All of the above is the correct option. All of the above is the right answer. I was on ONC. I had been on there for like 2 months in a row. There was this ONC nurse who I worked with very often, and so I asked her out on a date at the end of the rotation, and she literally asked me like, are you even old enough to take me out? Which was totally embarrassing, right? This was when I was an attending. I tried to grow a beard because people kept, I would walk into the room with the fellow and they would try to like look at the attending and they would look at my fellow or they would look at someone else. So I tried to grow the goatee, and maybe not for all Asians, but for this Asian, facial hair, it's not even an option. Our dialysis secretary actually pulled me aside and was like, "You look like Jafar from Aladdin. Just shave it. It looks terrible." I went to residency dinner when I was an intern. We just started, and I was referred to as some guy's little brother. And I did get yelled at by a spouse who thought I was a hospital volunteer handing out prescriptions, which is also totally embarrassing. Just a quick thing on the first option. Nurses are awesome. They will be like your best friends. They will save your lives. They will do things that you don't ever want to do. I mean, think of all the patients they have to clean and get out of bed and that kind of thing. Just be careful about asking them out, because you will work with them or their friends like every day for the rest of your residency, and if things go south, you just be careful about that, okay? That's my sixth pearl of wisdom for you. Just be very cautious about that situation. And again, let me reassure you, if I could make it through internship and residency, you guys will also. You'll do just fine. I'm sorry you have less than 10 minutes of a break, but if you guys have questions, just feel free to come on up and ask. Thank you very much.